Hi, I'm Dr. Meredith Mayo. I'm a sports medicine and shoulder surgeon. I'm going to be speaking with you this evening about staying active with shoulder pain. When we approach shoulder pain tonight, there are four main areas, particularly of degenerative or wear and tear shoulder pain, that I would like to review with you because they can affect people of a wide age range. The first is called rotator cuff tendinosis / impingement. What this refers to is pinching or inflammation of the rotator cuff, not tearing of the rotator cuff. The next section we'll review is actual tearing of the rotator cuff. The third is shoulder osteoarthritis, which refers to wear and tear arthritis deep in the shoulder joint. The fourth section is something called rotator cuff arthropathy. It's slightly more complicated, but also becoming increasingly prevalent in our society with more options for management than we've had in the past. So I think it's worth reviewing. For each of these four sections, I'll review how I evaluate a patient in terms of both their symptoms or complaints, as well as physical exam findings that can guide me towards thinking about our initial management. We'll also review what conservative or non-surgical management would be for each of these four categories. Lastly, I'll review the surgical options for each of the four categories and what the recovery for each of those surgeries would be like. A very basic review of rotator cuff anatomy. The rotator cuff is a set of four muscles. It's a group that forms the equivalent of a shower cap that goes on top of the ball of the humerus, which is at the ball and socket joint of the shoulder where your arm bone meets the shoulder blade. The four muscles include the supraspinatus, which is on the top and in the front. This is the one of the four muscles that is the most frequently torn in the rotator cuff and the most common cause of pain. The second rotator cuff muscle is called the infraspinatus. It's on the top, but in the back. The third is something called the teres minor, which is a larger muscle group that's in the back and towards the bottom. This one is rarely injured. The fourth is called the subscapularis. This muscle is in the front of the shoulder and controls rotating the arm inward. The first section of our four causes of shoulder pain includes rotator cuff tendinosis or impingement. Rotator cuff tendinosis or impingement is the most common cause of shoulder pain. What it involves is external compression on the rotator cuff and or the bursa. The bursa is a sac essentially of inflammatory fluid that can cause swelling around the rotator cuff and pain with range of motion, particularly pain when moving your arm away from your body. If you look at the diagram below, you can see the area that's delineated as being red represents inflammation both in and right above the rotator cuff. You'll see a structure called the acromion above this red area. This is actually a projection from your shoulder blade that functions as a shelf of bone on top of the rotator cuff and can be a cause for pinching. When I see a patient with rotator cuff tendinosis or impingement, I always ask them what their symptoms are. Often they'll say that they have shoulder pain in the front and on the side of their shoulder. They have difficulty with overhead activity and reaching far away from their body. Another common complaint is if you are in the driver's seat in the car and you have to reach toward the back seat to either grab or place something. People with inflammation of the rotator cuff, however, should not have weakness, as weakness is more consistent with a sign of actual tearing in the rotator cuff that we'll discuss later. The tendinosis or impingement that causes inflammation can happen slowly over time or can develop more quickly if you've had something like an overuse injury. For instance, if you've been raking leaves for 4 hours, your body's not accustomed to raking leaves for 4 hours, so this causes an acute flare of inflammation around the rotator cuff. Sometimes these inflammatory symptoms can come and go. They don't have to be consistent. When I hear a patient talk about these things, I generally get an X-ray series of the shoulder. The X-rays are often normal, but sometimes you can see what's called a hook on that structure I described called the acromion that goes down over the rotator cuff, causing pinching. When I examine a patient who has rotator cuff tendinosis or impingement, they have pain with what we call forward elevation of the shoulder, which you can see in the bottom left diagram on your screen. They also have pain when the shoulder is abducted or out to the side and internally rotated or turned down, as depicted in the lower right image of the screen. Both of these motions cause the rotator cuff to get pinched again under that acromion. When I see a patient who has both the history and physical exam findings consistent with rotator cuff tendinosis or impingement, it's safe to consider conservative treatment first. This is non-operative treatment. This can include a variety of things. Non-steroidal anti-inflammatory drugs, abbreviated throughout this presentation as NSAIDs, refers to the family of medicines you commonly know as Motrin, ibuprofen, Aleve, or Advil. There are also prescription versions as well. It also involves physical therapy. Now, especially during COVID, sometimes this physical therapy can be a home-guided program, or Kristen will speak with you as well about physical therapy options with working with a physical therapist directly. It can also include something called activity modification. This refers to altering how you use your shoulder throughout the day so that you don't cause the rotator cuff to pinch under the acromion. Lastly, if these things don't work or you've already tried them by the time you see me in the office, sometimes I consider trying a steroid injection for patients, particularly those with significant pain. You'll ask, when do I need surgery for this? Well, first and foremost, you don't ever have to have surgery for this condition. Surgery is an option for people who have pain for more than 6 months without improvement from the conservative therapies we've mentioned. Surgery in my hands, if all else fails, includes something called shoulder arthroscopy, which is minimally invasive shoulder surgery with about 3 to 4 1-centimeter incisions around the shoulder to essentially clean out this inflammatory tissue and create more space for the rotator cuff to move. It's a very short recovery because we're not waiting for any repair to heal or anything like that. So there are minimal restrictions after surgery. The next section, or step up from rotator cuff inflammation, is part 2, which is actual tearing of the rotator cuff. Rotator cuff tearing is extremely common in our population, not as common as just the inflammation, but it can affect up to 17 million people in the United States. It's responsible for over 4 million visits to the doctor's office in our country as well. Also, many of them are surgically repaired, which contributes as well to our healthcare system. It's not a completely benign or carefree procedure. There are potential complication rates, particularly including failure of rotator cuff repair, from anywhere from 10 to 14%, depending on the patient population. When patients with rotator cuff tears come into my office, their history is similar in some ways to the inflammation of the rotator cuff I previously described, but there are key points that I want to point out here that make them a little bit different. First is when they have a history of an injury. A specific traumatic injury makes me concerned right away that there may be a rotator cuff tear as opposed to just inflammation. Common injury patterns that can cause rotator cuff tearing include falling on an outstretched arm, as if you tripped on the curb and tried to catch yourself from falling on your face. Another thing is if you had to carefully lift a heavy object overhead and you weren't accustomed to doing so and felt an acute onset of pain in the shoulder. Oftentimes, actual tearing, you can hear a loud pop in the shoulder. You also can have an immediate loss of shoulder range of motion with rotator cuff tearing when it happens all at once. The second type of rotator cuff tearing is called chronic rotator cuff tearing. This is very similar to the rotator cuff inflammation I previously described, except for, if you notice this line in italics, it is associated with a loss of shoulder strength. These patients also frequently have significant pain at night that keeps them from sleeping. They also have significant difficulty with daily activities, particularly overhead. Risk factors for tearing of the rotator cuff include being in an age bracket over 60, using tobacco products, being diabetic, and actually we know that women are a bit more likely than men to have tearing as well. Again, when I get x-rays for patients with concern for rotator cuff tear, they are often normal. The physical exam for someone with a rotator cuff tear is slightly different. Some patients with significant rotator cuff tearing can actually not lift their arm overhead. When they attempt to, their arm actually drops to the ground against gravity. They can also have significant weakness when I resist their arm elevation or external rotation. Liftoff strength refers to having difficulty with the ability to turn your arm inward. The diagram below refers to what I call the drop arm sign, where the practitioner in the navy blue uniform is lifting the arm up and the patient in the gray tank top simply cannot even hold his arm up against gravity when the practitioner lets go and his arm drops toward the ground. Rotator cuff tears are managed differently in different patient populations. If you've had a specific injury or trauma, you should be evaluated by an orthopedic surgeon. This would likely involve getting an MRI without contrast to evaluate the soft tissues of the structure. You should get an MRI without contrast to evaluate the soft tissue structures of the shoulder, as x-rays do not show us the soft tissue structures involved in rotator cuff tearing. Then sometimes initial conservative treatment is appropriate. It is appropriate if the patient only has evidence of a partial rotator cuff tear or in a slightly older population with a chronic tear. That initial conservative treatment is the same as I previously described for rotator cuff tendinitis. It includes the nonsteroidal anti-inflammatory drugs, physical therapy, activity modification, and steroid injections. When do patients with rotator cuff tears need surgery? Anyone with a traumatic tear that has completely torn the rotator cuff tissue off of the bone, as depicted in the image on the lower right of the screen. Also, patients with significant weakness or significant pain despite the above mentioned conservative treatments. What does rotator cuff repair surgery involve? For a traumatic tear, they're usually quite easy to repair because the tissue has so quickly been torn off the bone. The series of images on the left shows what an arthroscopic repair entails. The top image with the label saying torn tendon shows where the rotator cuff normally attaches into the top of the humerus or arm bone. The next picture down, slightly to the left, shows a small instrument being inserted in the shoulder where the rotator cuff is cleaned. The third image down shows how we insert anchors or screws made out of a calcium material into the bone that have stitches or sutures attached to them. These are then passed through the rotator cuff tissue, then tying it back down to the bone, as you can see in the final fourth image on the bottom, where the rotator cuff is now compressed again against the bone. Again, for acute tears, the repairs are quite simple. For chronic tears or patients who have had tearing for some time, often greater than 6 months, we can attempt arthroscopic repair like we can for traumatic tears. However, oftentimes the repair is not quite so easy. It requires adding additional tissue or supportive tissue, additional sutures, more so than the number of sutures or anchors I'd use in a traumatic tear. And sometimes there's even a newer procedure you may have heard of called a superior capsular reconstruction. This is a complex procedure I'm not going to go into right now, but what it involves is essentially rebuilding the rotator cuff with soft tissue. Rotator cuff tears have a longer post-operative course than simply the surgery previously described for rotator cuff tendinosis or impingement. That's because we have to let the rotator cuff heal. This requires being in a sling with a pillow, as you can see in the image depicted, for a minimum of 4 to up to 6 weeks. This also involves no lifting in your operative arm for a full 12 weeks. A full recovery is anywhere from 4 to 8 months, depending on the size of the rotator cuff tear and any additional procedures performed at the same time as the rotator cuff repair. Our third section, moving away from rotator cuff tearing, is something called glenohumeral or shoulder arthritis. Glenohumeral arthritis is wear and tear arthritis. However, there are symptoms or histories that can lead us to think about this in certain patients. So the main difference with this as opposed to rotator cuff symptoms is that patients often come in complaining of significant stiffness. Stiffness in all ranges of motion, not just certain planes as with rotator cuff tearing. Again, this is wear and tear, meaning this happens slowly and over time. They can have a popping, grinding, or sandpaper sensation with range of motion of the shoulder. The pain is also much deeper, really deep down in the shoulder. People can even often point into their armpit as the source of pain. Risk factors for developing shoulder arthritis are quite broad. We know that throwing athletes, things like baseball or lacrosse, can cause people to develop shoulder arthritis more rapidly than those who don't perform those type of repetitive overhead motions. Rheumatologic disease like rheumatoid arthritis or other types of inflammatory arthritis can predispose people to shoulder arthritis. Having a history of dislocating your shoulder has been well borne out in the orthopedic literature to progress to shoulder arthritis in a large proportion of patients. Prior broken arm bone or proximal humerus fractures, as depicted in the upper right X-ray on this page, can also predispose people to arthritis, whether or not you have surgery for this fracture. Again, I get a series of X-rays for patients where I'm concerned about glenohumeral osteoarthritis. Particularly, these X-rays need to be upright as they help me evaluate certain types of bone wear patterns in patients. It also helps me determine if the arthritis is mild, moderate, or severe. Oftentimes, X-rays are not sufficient if there's evidence of arthritis on X-ray, and further imaging such as an MRI or a CAT scan is necessary to determine the next step of treatment. Here's an example of an X-ray for a patient on the left with a normal shoulder. We're looking straight on at the shoulder. The arm bone or humerus is in the right of the left-hand picture, and you can see at the top it forms a nice round ball and sits in the associated socket. Compare that ball and socket to the picture on the right. You can see that the bone is not perfectly round and there's not space between the ball and the socket. This is the term when you hear bone-on-bone arthritis. This is what it means. It means on X-ray that there's not space anymore between one side of the joint and the other. These are the other series of X-rays I get to determine the bone structure involved in arthritis. They just give me slightly different views of the shoulder joint themselves and help me determine the appropriate treatment. This one looks at the shoulder from the side, and I can see the shape of the person's shoulder blade and whether or not the ball is centered on the socket from the front to the back. This is a view, if you can imagine, with your arm out to the side like a chicken wing, that shows me an additional view of the socket. Again, if we look at the ball on the left and the socket, you can see there's space between them. When we look at that on the right, again, there's no space. There's irregularity of the ball and the socket, and it's bone-on-bone arthritis. This is an MRI of a shoulder for arthritis. We can see all the white areas on the MRI in the upper left corner show evidence of what we call cysts, or evidence of significant chronic inflammation and excessive stress across the shoulder joint that's caused the joint to wear down and cause the bone to react in response to the arthritis. This is very advanced arthritis with total loss of cartilage coating. The cartilage coating would normally be adjacent to where the white circular structures in the bone are. How do people with glenohumeral osteoarthritis present in my office? Well, like I mentioned before, they have motion limited in all directions. Particularly, something called external rotation is disproportionately lost. If you look at the cartoon at the bottom of the page, You can see on the left that the patient has the arm rotated towards its stomach. As he starts to try to rotate his arm outward toward the position in the picture with the gray line around it, that's external rotation. Someone with osteoarthritis of the shoulder, particularly severe osteoarthritis, cannot rotate their arm out as far as that man is indicating again in the gray box. Also, I'll notice noise and grinding with shoulder range of motion on exam. Note that I haven't mentioned that these patients necessarily have weakness. They frequently do not have weakness. It's truly deep-seated pain and stiffness. What's the appropriate management for glenohumeral osteoarthritis? Again, initial conservative treatment is a nice place to start. Steroid injections have a larger role in arthritis of the shoulder, more so than even rotator cuff management. The next conservative treatment option would be something called NSAIDs. We discussed what those medications were, and they're also appropriate for this. Physical therapy works well in mild and moderate osteoarthritis, but it does not help much in severe or advanced osteoarthritis. We're hoping with future orthopedic investigation that other types of injections with modifications of your own blood could be distributed into the shoulder joint to calm down inflammation and potentially one day reform cartilage. That's the ultimate goal in orthopedics, is to rebuild cartilage. So again, when do I need surgery for this? When you've had pain despite the conservative treatments we've mentioned. Are you noticing a theme here? It's pretty much the same algorithm for each shoulder condition. But when people have progressive or severe loss of motion in the shoulder, sometimes it's better to jump to surgery than trying some of these conservative treatments. If you get too stiff, sometimes the surgery itself becomes more complicated and your outcome from the surgery is less predictable. Surgery for glenohumeral osteoarthritis is twofold. The first is for mild or moderate osteoarthritis. This is something called comprehensive arthroscopic management. This involves removing bone spurs and loose bone or cartilage fragments that are generated from arthritis so that you don't have that grinding and popping sensation. Additionally, we can stimulate the bone marrow by drilling small holes in the cartilage defect. Lastly, we can release some of the soft tissue or capsules surrounding the joint to provide the patient with additional mobility. This has a fairly quick recovery because, again, we're not really waiting for anything to heal. The earlier you can move from this procedure, the better. For more advanced shoulder arthritis, the surgical option is traditionally a total shoulder replacement. If you look at the image on the left, again, we see that irregular ball and socket joint. The image on the right depicts an anatomic or normal shoulder replacement. This involves replacing the ball with a metal hemisphere attached to a stem that goes down the bone in the humerus. The socket side is actually made of plastic. The plastic does not depict on the X-ray, but you can see the plastic as being represented as this black space adjacent to the white ball in the picture on the right. What's the recovery like from a total shoulder replacement? It's fairly similar to recovery from a rotator cuff repair. A total shoulder replacement can now be performed as an outpatient or same-day surgery or an inpatient surgery. When you stay in the hospital for this surgery, if you elect or need to do so, usually stay 1, maybe 2 nights. So it's a fairly quick recovery from an inpatient perspective. You do still wear a sling with a pillow for 6 weeks like you do for the rotator cuff repair. The physical therapy initiates 2 weeks after surgery and goes for a minimum of 12 weeks. And again, full recovery is usually 4 to 6 months after surgery. We're getting advanced here, you guys. Our last stage is part 4, which is rotator cuff arthropathy. Now that we've reviewed what rotator cuff tearing is and what glenohumeral osteoarthritis is, imagine rotator cuff arthropathy combining those two categories. So patients with rotator cuff arthropathy have a history or symptoms presenting as a long history of known rotator cuff tear. Maybe you fell off a ladder 20 years ago and were told in the emergency room, hey, I think you might have torn your rotator cuff, but you never went to the physician or orthopedic surgeon to have it evaluated. Well, your rotator cuff may have been torn for 20 years and is now causing the rotator cuff arthropathy symptoms we'll review. Additionally, patients can have a complete loss of shoulder function. So this is not the stiffness of arthritis. This is a true inability in terms of weakness of being able to move your shoulder. Oftentimes, patients will have a history of off and on chronic shoulder pain and then have a more recent minor injury that kind of pushes them over the edge, as in the straw that broke the camel's back. And then their shoulder function and pain gets significantly worse. Risk factors for developing rotator cuff arthropathy include age over 70, females, rheumatologic disease. I also include in this category people who have a history of prior rotator cuff surgery. As we discussed at the very beginning, rotator cuff repair surgery is not perfect. And if people have had a failure, particularly a failure for some time, they can then present with rotator cuff arthropathy. First step again with rotator cuff arthropathy patients is to get an X-ray series. So again, this is very important that this be upright. It determines the degree of change bony anatomy that can progress with time. Again, this is often followed by obtaining an MRI or CAT scan for surgical planning. These are the X-rays of a patient with rotator cuff arthropathy. We've reviewed a number of normal shoulder X-rays so far, and I want you to look at the X-ray on the left. Again, we see the arm bone to the right of the picture on the left. At the top, it forms a ball. But this time, if you carefully look at the ball, it's not centered in the socket. That's because the rotator cuff here is deficient. The rotator cuff helps hold the ball down in the socket, and when it has been torn and retracted or pulled back for a long period of time, it can no longer do its job, and the rotator cuff, the humeral head starts migrating proximally or upward towards your head. If you look at the images on the right here labeled A and B, B is an example of a normal shoulder position for the glenohumeral joint. Again, you can see the ball is centered in the socket. In picture A, the ball is up in the socket. You can see where it says 6 millimeters. That means it's very close to the acromion, or that structure we reviewed at the beginning that can pinch the rotator cuff. Here are other examples of plain X-rays in different views that show the ball of the humerus or proximal aspect of the humerus migrating toward the head superiorly, causing this form of arthritis. We're reviewing an MRI here again. This MRI is different than our prior one. You can actually have a good amount of preservation of cartilage in rotator cuff arthropathy, but particularly if you look at this MRI image on the right, this is looking straight on at the shoulder like we have in so many of the X-ray images. You can see that ball. You can see the socket adjacent to it. You can see that the ball is not centered in the socket and that there's a large white gap above the ball. That large white gap is where your rotator cuff tissue or tendon should be, pushing that ball down into the socket. How do patients present with rotator cuff arthropathy in the office? Their physical exam, again, is with motion limited in all directions. Can be true inability to move, or it can be what's called pseudoparalysis. And what pseudoparalysis means is that I could take your arm and move it however I wanted, but you cannot do the same. It also involves muscular wasting in the back of the shoulder. Wasting refers to the muscle almost disintegrating. If we look at this picture in the lower right, you can see this gentleman's right shoulder from the back. You can see this bony spine along his shoulder blade. The rotator cuff muscles live above and below that bony spine. You should not be able to see the bony spine so prominently. This means that his rotator cuff muscles have essentially been disintegrating for some time. This is muscular wasting. Alternatively, in the front of the shoulder, you can see bony prominence as well. What are the initial conservative management options for rotator cuff arthropathy? Again, we can attempt steroid injections, particularly in elderly patients who may not be great surgical candidates. We can also revisit that class of medications called NSAIDs. Physical therapy works very well for this, again, particularly for mild or moderate disease. When do these patients need surgery? When patients have significant pain, particularly at night again, despite conservative treatment. Also, when they've had progressive or severe loss of shoulder range of motion that's preventing them from doing their daily activities like showering or eating. What are the surgical options for rotator cuff arthropathy? At this point, this would be something called a reverse total shoulder arthroplasty or replacement. You can see this compared to the prior normal shoulder replacement I showed you. This version has the ball on the socket side and puts the socket on the ball side. The biomechanic reason for that is to compensate for the lack of rotator cuff muscles. This puts more reliance on the deltoid muscle, which is the muscle you feel on the outside of your arm where you normally get your flu shot. Hopefully you guys have all gotten your flu shot. And at that point, that muscle can compensate or make up for the deficient rotator cuff. What's the postoperative course for reverse total shoulder arthroplasty? Very similar to shoulder replacement, same day or inpatient surgery with a brief stay. They also will need a sling with the pillow for 6 weeks. Again, progressive physical therapy for 12 weeks. Overall, this full recovery is 4 to 6 months. The main difference with this type of shoulder replacement, as opposed to a traditional shoulder replacement, it's not an option for people who have to do a lot of repetitive heavy lifting. In this form of the shoulder replacement, any type of repetitive heavy lifting more than 15 pounds can cause loosening of the components. So it's not ideal for people who are still doing heavy labor with their arms. So again, to review, going back to our first slide, we reviewed the 4 common causes of shoulder pain: rotator cuff tendinosis or impingement, rotator cuff tearing, osteoarthritis, and rotator cuff arthropathy. We reviewed how these patients are evaluated and managed initially. We also reviewed the surgical options in each of their recoveries. Thank you very much for listening this evening. My family and I are so happy to be back in Colorado, and I thank you for your time. I'd be happy to answer any questions that you have at this point.
You have heard Dr. Mayo speak to staying active with shoulder pain. My name is Kristen Matoba. I am a board-certified sports physical therapist, and I'm going to speak to the physical therapy side of shoulder pain. So first, we're going to talk about what is physical therapy. Physical therapists are movement experts who improve quality of life through prescribed exercise, hands-on care, and patient education. And that is per the American Physical Therapy Association, or our governing board. We examine, evaluate, diagnose, and treat neuromusculoskeletal dysfunction in a non-surgical capacity. So that big fancy word, neuromusculoskeletal, just means that it's related to nerves, soft tissues, or bones. Why is Boulder Center for Physical Therapy different? We're different for a lot of reasons, but we believe in individualized care tailored to your needs and your body. So we don't have a one-size-fits-all approach. Anytime that we have shoulder pain, we're going to tailor it to your body and your specifications and exactly which tissue is dysfunctional and what we're trying to fix. And the exercises that we give you, it's not like Google where you go and look up and they're going to give you an umbrella of general shoulder exercises, because what might be wrong with one person is not always wrong with everyone. And so we really do individualized care here with unique exercise programs and unique manual therapy depending on what you need. We provide one-on-one hands-on attention and care. If you go to other physical therapy places, sometimes the expectation will be that you're being seen with another person, or that you are not getting that therapist's full attention. We believe that you are our priority when you're in the clinic, and so that's how we treat it. Our therapists specialize in orthopedics, sports and hand therapies. We believe in the most up-to-date evidence-based practice and care for the most efficient, safe, and complete recovery. So a lot of techniques out there are older, or the evidence doesn't support certain things. We definitely try and stay on the forefront of evidence and medicine to give you the best care possible and to give you the most efficient recovery. So something that once took a long time based off of old evidence now can be done a lot faster, a lot safer, and a lot more completely, so that hopefully you don't have a recurrent injury and that you are safe moving forward. We are a multidisciplinary team composed of doctors, physician's assistants, physical therapists, and strength coaches to give you the most comprehensive treatment possible. So we really do believe in a team approach here. We really do use all of those people. And so all of 1, 2, 3, all of those people might be a part of your medical team. And I think that gives you the best treatment possible. So we really are a team-oriented facility. How can physical therapy help my shoulder? As physical therapists, our job is to find the cause of the dysfunction, which just means what tissue is damaged. Is it a tendon? Is it a bone? Is it a ligament? Is it a joint? And we do that in collaboration with the doctor or the physician assistant. And our job is to provide the best environment for healing. So we believe that the body can, in a lot of circumstances, self-heal. And if that is, and you're a candidate, meaning a non-surgical candidate, and you can, then we'd like to see you conservatively heal. And we want to give you the best environment for that tissue. So things like blood flow and appropriate exercise and dosage and things like that. Conservative healing takes time, especially with chronic injuries or degenerative things. That takes a long time. If you have had this pain for 10 years, I cannot fix it overnight as much as I want to be a miracle worker and wave my magic wand. A lot of times, conservative healing without surgery takes time. And so put your patience pants on when you come to see us, but a little bit of consistency and diligence can go a long way to avoiding surgery or just improving your shoulder pain. So anatomy and biomechanics really dictate what a healthy shoulder environment looks like. So we treat based on that anatomy, as opposed to some more holistic approaches that might use different philosophies, treatment philosophies, different topographical body maps, all kinds of different things. We really care about the anatomy of the shoulder and how it's supposed to move and why yours is abnormal. And so we look at why it's abnormal and how do we bring it back to normal anatomy and biomechanics. We also care about finding the appropriate fit for you. Fit stands for frequency, intensity, time, and type of movement. And so a lot of times movement can fall on a spectrum. So for example, if a bone is healing, some stress is okay. Some moderated stress is okay. Certain impactful stresses are not okay, and they prevent the bone from healing. So that's just one example of the fact that it's our job as physical and occupational therapists to appropriately stress tissues at certain times in your rehab process. That will obviously make a difference if you are post-op after surgery, or if you are conservative healing. There are so many factors that go into that, but that's why you come to see us as a professionals, to tell you what's too much, what's not enough, and how do we judge that fit. So we're going to talk really briefly about shoulder anatomy. It's very complicated, but perhaps the most important is that if you look at the picture on the left in that like neon blue, you will see that your shoulder is a ball and socket joint. The bony anatomy of that really looks like a golf ball on a tee. And so the ball is significantly bigger than the socket. We're going to talk about structures of the shoulder briefly, but that's pretty much what it is. It is a very mobile joint. It moves in various directions. Its purpose is to move your arm, as opposed to like your elbow, which is the purpose is to provide stability. That joint is inherently built differently. It is not a ball and socket joint, but the point of the ball and socket joint is that it moves a lot and it should move freely. We care very much in physical therapy about your rotator cuff. That rotator cuff consists of 4 muscles: your supraspinatus, your infraspinatus, your subscapularis, and your teres minor. Those are very important because they help to keep your ball in the socket. So for the basics, the shoulder is made up of tendons, ligaments, muscles, and a labrum. As I spoke to before, the bones are the ball and the socket. They're called the humerus, which is your arm bone, and your scapula, which is your shoulder blade. Your scapula will also articulate with your ribs, which is really important in terms of movement as well. So we really holistically address your shoulder complex as opposed to just the ball and socket joint when you're in physical therapy. That also ties very much into neck mobility and compensations like that. And so we have to address, is it coming from the neck? Is it coming from the shoulder? Is it going up or is it going down? So we really try to holistically treat and find dysfunction surrounding the entire shoulder complex. Tendons connect muscle to bone. Ligaments connect bone to bone. They are passive, meaning that they are, they're not contractile. Muscles, they are contractile and they will provide movement. So ligaments are going to provide your passive stability. Think of like dislocating a joint where the ball actually pops out of the socket. You've lost that passive stability to the joint. And muscles are going to provide that active stability. So if you tear your muscle of your rotator cuff or you tear some other muscle, you might have, I call it slop in the system. So extra movement in that joint because either the passive, the active, or both kinds of structures have been compromised. The labrum is a soft tissue structure that helps to improve the ratio of that ball to socket joint. So like I said, it's like a golf ball and a tee. So that labrum is there to increase the surface area of the socket so that they fit more appropriately in terms of size. And it also provides a negative pressure to that joint so that you're not dislocating the ball from the socket. And then we talked a little bit briefly about the rotator cuff. Again, 4 important muscles. The reason why in physical therapy we are all about your rotator cuff and its ability to fire is because, again, that is active stability for a mobile joint. So that rotator cuff is what keeps your ball inside of your socket. There are many, many kinds of shoulder dysfunction that happen when your rotator cuff is not firing appropriately. Also, that we have a saying in physical therapy that pain changes motor control, which is a very fancy way of saying that if you have pain or something has become dysfunctional, that muscles do not fire in the same way. And so sometimes it can be a cyclical incident or event. And so you get shoulder pain for any various numbers of reasons. And now your rotator cuff isn't firing appropriately because it's trying to work through pain, and muscles don't really fire as well. They're not as coordinated. They're not as strong when they are trying to work through pain. So that's the part that we call the neuromuscular component, the nerve meeting the muscle. And our job is to hopefully correct that as well. So it's not just about strength, but also in a broad sense, I'll call it coordination and making sure that those muscles and nerves are firing appropriately to each other, especially if you have pain. So again, that's what keeps the ball inside the socket. And we're going to talk about a spectrum of injuries when it comes to your rotator cuff, which is really where I'm going to spend the vast majority of my time here, is talking to the rotator cuff injuries as opposed to shoulder dislocations or arm fractures or frozen shoulder. If you have questions, you're more than welcome to ask me those questions at any point, but I'm really going to focus on the rotator cuff today. So I generally will explain to people that the rotator cuff injuries really can be described kind of on a spectrum. So on that spectrum, at one end of the spectrum, you have what I'll quote unquote call the more simple issue, which is inflammation and or bursitis. So a bursa is a fluid-filled sac that sits in above your shoulder, so above your ball and socket, but below your collarbone. And so if you look in the picture there, you'll see that red vibrant point. The upper red circle is a bursa. That bursa is normal. It's an anatomically fluid-filled sac, and it helps with compression of that space. So on one end of the spectrum, you could just have inflammation where that tissue is irritated, it's swollen from a cellular level, it has increased cells around that area because it's trying to heal. That's probably, it doesn't feel like it, but it's probably the more simple end of the spectrum. It's typically non-surgical, but it can respond to injections if it's being persistent. But that's a great one for you to come into physical therapy and just get the mechanics right, and get your neuromuscular and your strength stuff right. And a lot of times those things will self-resolve. The middle end of that spectrum, or the middle of that spectrum, is tendinopathy. Tendinopathy is an umbrella term, meaning there's something wrong with the tendon. Now, you could have an inflamed tendon, that's tendinitis. And so again, it's an inflammatory issue. It's swelling around that tissue or irritation around that tissue. You could also have tendinosis, which is a degenerative issue. Think of it more like a rope that is fraying. So you're starting to get wear and tear surrounding that tendon, excuse me. It could be swollen. There could still be swelling in there, but many times those chronic tendinopathies are more about actual tissue dysfunction, so actual degeneration of the tendon versus inflammation in which the tendon is still intact. The next end of that spectrum is really tears. So partial tears, you could have, again, if you bring back to the rope analogy, you could have one thread that is torn, or you could have 9 out of 10 threads that are torn. You could have a degenerative tear, which again is that fraying rope, or you could have an acute traumatic tear. So that tear could be old or it could be new. Many times, if it's new, you know what you did. If it's not, then a lot of times we'll find degenerative tearing given age gender matches. And then full tears are pretty much what they sound like. You fully torn that muscle. So that muscle is no longer intact. The two ends of that tear are no longer touching. And a lot of times that muscle will retract or shrink back away from its opposite side. And so that's kind of the spectrum. If you are looking at a full tear, many times it could be surgical. I have plenty of patients that also decide to treat full tears conservatively. It will entirely depend on what your unique situation looks like. How much is torn? How long has it been torn? Was this associated with a trauma? Is it just degeneration? How functional are you? Can you lift your arm over your head? Can you lift a gallon of milk? There are a lot of factors, both functional and from a tissue specific impairment, that go into, am I surgery or am I not surgery? Am I injections or am I not injections? Am I PT or am I not PT? Every single person will be different because every tear or non-tear or inflammation, etc., will be different. So that's kind of the spectrum of rotator cuff injuries. Again, I'm happy to answer questions if you guys have any. But a lot of times, like I said, it's going to be unique to that individual and what's happening. Perhaps the most common thing that I get in the clinic falls under the inflammation or tendinitis or partial tear category. I want you to go ahead and take a look at the picture. In the front, starting at the right, you're going to see, you're looking at someone from the front. You're going to see their collarbone, which is also called the clavicle. And you're going to see your acromion, which is the hook of your shoulder blade, your scapula. Those two come together to form a bony tunnel. And why that is so important is because if your rotator cuff, as we talked about before, is not firing appropriately, that means your ball is not stable inside of your socket. And what ends up happening is the ball will ride upward in the socket. And you can see that both that bursa and that supraspinatus tendon, that rotator cuff tendon, are going to get pinched if that ball rotates up in the socket. We have a very fancy term for that in medicine called impingement. So many times when I see shoulder pain, it is subacromial, which means below that bony tunnel, subacromial impingement or pinching. There can also be subacromial impingement because off of the collarbone or off of the acromion is bone spurs. And so if you have an extra piece of bone there, or your anatomy is sloping or things like that, ultimately it just means that you have a smaller space there and you're more likely to get impingement. So impingement could, again, it could include inflammation. It could include tendinitis or tendon irritation. It could involve a partial tear if that bone spur starts to tear at that tendon. But that's probably one of the most common things that we will see in the clinic is subacromial impingement. So hopefully that gives you a good idea about the spectrum of things that can go wrong in the shoulder. And then perhaps the bigger question, how do I keep my shoulder healthy? So let's say that you have tendinitis, or you have inflammation, or you have a partial tear, or heck, you even have a whole tear. How do I keep that shoulder healthy? I put this one at the top for a reason, and that is posture. So if your shoulders are very shrugged up, or they are very forward leaning, or both, that will close off that space that we talked about. That means that your shoulder is not getting appropriate blood flow. It means that the mechanics of the shoulder are not correct. And it means that every time that you go to lift your arm over your head, you're going to pinch or cause dysfunction of your rotator cuff. So postural correction is huge, especially because so much of us spend time sitting in front of a computer, or sitting for work, or sitting to read or watch TV, or the vast majority of our lives, sadly, is spent sitting. And so the vast majority of our time should probably be spent on postural correction. So it's something we all deal with, but we definitely have the tools to help you out with that. And that's very much an endurance thing, where after prolonged periods of time for postural correction. Stay active. So I've seen a lot of people that come in, and this kind of speaks to the third one as well. I've seen a lot of people that will come in that have shoulder pain because of non-use. So prime example, in the year of 2020, when we've had COVID, I've had plenty of people fall off the exercise wagon. No judgment, no harm, no foul. But sometimes what happens is your shoulders get weak because you haven't been using them. And again, if you don't have that rotator cuff strength, your ball will not sit appropriately in its socket. And so staying active, staying strong, keeping your arm strength up, and keeping your postural endurance are two of the biggest things that you can do to keep your shoulders healthy and to prevent any kind of degenerative or overuse injury. That does not speak to traumatic injuries where you fell on your arm or you fell on your shoulder. That will be different. That leads right into the next one: reduce the risk of falling. If you have a balance impairment, come in and see us, especially as you get older. Everyone falls, but our body does not recover the same way as we get older. And so A, the healing time takes a lot longer as we get older, and B, we're just at a higher risk of more severe injuries should you fall. So if you have a concern for falls, please come in and see us. We can definitely work on balance. And if it's a neurological dysfunction, we can certainly address as much as we can, and then give you the resources to address that further, so that you don't have that risk of falling. If we can avoid breaking bones and we can avoid tearing rotator cuffs, we definitely want to do that. Avoiding overuse. And so we definitely want to prevent especially painful overuse. So many times people will ask me the question, if it's hurt, should I push through it? Is this something that's going to go away? Should I just ignore it and keep strengthening? Or is this something that I should back off and recover from? So I would say you definitely need to avoid using something that's painful. And that's where we come in, because we're going to give you things to help baby step you towards what you want, but not in a painful capacity. So sometimes it's a matter of looking at your situation and seeing the muscle imbalances and saying, okay, well, right now it's painful for you to lift that weight over your head. Let's get this set of muscles stronger. And hopefully once that has been addressed, it should no longer be painful for you to go over your head, as opposed to trying to push through something that might just make it worse. So please come in and see us if you are feeling like you can't do something because it's painful. Generally, you shouldn't be living with pain in your shoulder, especially if it's something new. So And then if you have any pain, please seek help. Come in and see us. That's what we're here for. We want to get you pain-free. We want to get you better. We don't want you to sit around and wait for 2 to 3 months to see, is this going to get better? Just come in and see us. I'd much rather get you in the beginning and be able to solve your problem in a matter of a week or two, as opposed to waiting for 8 months, a year, 2 years, 3 years, where now this tissue has become chronically dysfunctional, and we have a much bigger job in PT to do. And it means that you're likely not going to heal nearly as fast because you were pushing it through pain. So please come in and see us if you have any questions about any of the above, or if you just have any questions about shoulders in general. We are here for you, and we want to give you the best care that we can. So if you have any questions, feel free to ask them. Again, any surgical questions, I'll direct those to Dr. Mayo, or any injection questions. She's great for that. But I am happy to answer any questions that you may have about conservative treatment or physical therapy. Thanks so much.